Hi everyone, and welcome back. I hope you all had a nice break and you can hear me okay. So apologies for earlier. There was definitely problems with YouTube. There was problems with people getting in, so we are going to repeat the first two sessions, but everything has been running smoothly for now. I'm absolutely delighted to introduce Ed, and he is going to talk to us about all things occupational therapy.
I can't talk about everything. We're huge. We're massive. We're going to take over the world.
Over to you, Ed.
Oh, thank you, Rachel. Oh, thank you for inviting me to talk about occupational therapy and what's been happening during the COVID pandemic. I've got a bit of a presentation. Let's go to that. Occupational therapy, it's huge. It's we work in so many different areas, so I'm only going to be able to touch on a few things really. But for those of you who don't really know much about occupational therapy, here's a bit of a kind of a quote from the Royal College of Occupational Therapists if you look at their website. So occupational therapy takes a whole person approach to both mental and physical health and well-being, and enables individuals to achieve their full potential. So we're kind of like the only health and social care profession that really we're kind of trained to look at mental health and physical and mental abilities, cognition, psychology side of things as well. And what we're concerned about is our occupations, those things that we want to do each day, those things that are quite important to us. Sometimes we put it into broad categories of being able to look after ourselves, looking after our home, getting out and about, doing our hobbies and interests, accessing education, going to work. So a lot of things. And underpinning all of that is some of the spiritual aspects as well. So you can understand through this pandemic, a lot of our occupations have been totally disrupted. What are the things that we've enjoyed doing? It might be socializing with people. Our jobs have changed. Our studies have changed. Not being able to hug our family members, it's been quite a change. But for some people, I'm an introvert, so it's been kind of nice not having to see as many people and interact with people. But actually, in terms of some of the things that I enjoy doing, being able to go outside and walk in nature and spending that time is a little bit difficult, or having the impact of the work and the pressures that we're all feeling, not being able to take care of myself as well, through yoga, exercise, and diet. So that's a bit about occupational therapy. Now, in about June, July last year, the Royal College conducted a survey to the members. So feel free to have a look at that. And it kind of looked at the impact of COVID-19 pandemic on occupational therapy in the United Kingdom. So there was, I think, over 1,000 participants there. So there's some quite big themes coming out quite early on into the pandemic. So some of the things that I've kind of thought about is certainly things about redeployment and the hours of work and shift patterns that a lot of us have had to change and adapt to, really, due to our response to the pandemic. It's been nice that from intensive care kind of units, that there are more posts for occupational therapists. This is probably an area that's been neglected for many years. We've been able to contribute a lot to the rehabilitation and prevention of problems when people are in intensive care, and some of the follow-up work that's needed, that people from intensive care can have post-traumatic symptoms, delirium, cognitive changes, and we're really in a good place to really help with that. And some of our colleagues have been redeployed to help the proning side of things for people in intensive care. Pediatrics. A lot of us work in pediatrics, and were redeployed initially, but I think the governments, particularly in Wales and England, have learned from this experience of not redeploying paediatric occupational therapists, and to protect them in their roles to deliver services to children. Certainly from our acute physical hospital point of view, there's been, crudely put, a push for discharge from hospitals to free up the beds for patients who are more ill, more critically ill as well. And some of you would probably see that the government has kind of mandated a discharge to assess models are implemented in these acute hospitals. So it's a model that's been in place for a few years for a few organisations, but certainly it's a push that is going to happen. So that's going to be quite a lot of big changes in the acute services out there. And then my mental health and learning disabilities colleagues, you know, carry on doing the job the best they can with the restrictions that are there. But also, I think we can understand that these changes have been quite a strain on our emotional and mental health. Raising our anxieties, not being able to carry out some of the things that we would normally enjoy doing, our occupations, which will actually, help us to feel good and actually help us to stay mentally and physically healthy. And actually, that's a particular challenge, perhaps, for some of our service users, where we're having to be creative to try and support them with their mental well-being as well. And that goes across any of our fields that we work in. It's not just our service users who access mental health and learning disability services.
Ed, can I just check, did you want to share any slides?
Oh, am I not sharing slides?
No,
Oh, that's
it's
naughty
all right.
of me.
We're only 6 minutes in, but I just remembered you had some pictures to share where you were talking. I mean, I'm so engrossed in what you're saying. I didn't even kind of realise. So especially because
there you
look
go.
at this next slide.
There's that. There's me. So we're just looking at my face all the time.
It was very nice to look at.
Thanks. Of course, we and have, you and I have a secret, don't we? And yeah, I'm not going to share with anybody what my secret is. Anyway, back to more important things. So midway down, we're talking about so as occupational therapists, some of us are now trained to be vaccinators, really, which is kind of great to see. But it kind of does also compromise some of the service delivery if we're kind of pulled that way. But actually, for some of us, it's quite important to be delivering the vaccines as much as possible. And of course, a huge explosion of virtual working and home working and trying to use technology like this, really. And another biggie is student placements. The offers of student placements have been extremely challenging. And as students, you really understand and you're really feeling that. And yes, sometimes placements are cancelled, or how can we deliver quality placements in these challenging times. What's also happening is that long COVID clinics, so hopefully some occupational therapists are involved with some of those clinics or along the pathway. So if people are being assessed in long COVID services, then they'll be referred to rehabilitation services for being occupational therapists. So, particularly where the ones you particularly access when you've got fatigue or cognitive issues as well. We tend to be quite numerous that way, but of course also involved in physical rehabilitation. But the ultimate aim, like I say, is about occupations, returning back to those activities that are important to you and help you to feel, give you quality of life and makes you you. I think what's also been interesting in the political agenda and how it's also affected occupational therapy, particularly from the Black Lives Matter movement, is this awareness and this kind of introspection about us as a profession and our professional bodies around equality, diversity, and inclusivity. And we got to keep on going. It is making people think about the racism that is there, LGBTQ plus communities, neurodiversity, disability. We are, it is on the agenda, and we have to keep going, and we will have to contribute to that to bring about more positive change. And I think as rehabilitation professionals, we have realised that the impact on being able to deliver rehabilitation to the communities that we serve, and that is something that we're all pushing for, is to not forget rehabilitation. And actually, as we get further and further through this, that is even more and more important as people are dealing with long COVID and other health problems, and also just our overall well-being as a society, really. So this was me in July 2020. This is me today. I wouldn't say that is any better, but it was tough at that time. So for me, I normally work in a community neurology team in East Anglia in England. And initially the thoughts was that our team would be redeployed fully into the physical community team. So providing some care, equipment, preventing hospital admissions, and that was initially where I was going. So some of my work was supporting my colleagues to train the wider multidisciplinary team on some of the equipment issues, so that it doesn't need an occupational therapist to assess for toileting equipment when a nurse, a physiotherapist, an assistant practitioner, rehabilitation support worker could make that kind of judgment and prescribe and supply that equipment. So a whole range of things. But very quickly it was like, no, Ed, you're not going there. You're going to be moved to an integrated discharge team based at the local acute hospital. So I was there to help kind of organise care packages to support discharges from hospital and just provide some advice on some of the more complex discharges. It's a kind of a role I've had before when I've worked in acute hospitals as supporting discharge planning, assessing for equipment and people's needs, and looking at care packages. So that's kind of was tough for quite a few months working. I normally work Monday to Friday, 7.5 hours days, to doing 12-hour shifts, having to work weekends and bank holidays as well. So they were quite intense as well. And as you can imagine, discharges and the pressures to support people going home who are medically optimized was quite intense work. Then in mid-August last year, I was moved back to the community neurology team, but also because of the senior occupational therapist from the stroke early supported discharge team was working from home and kind of did a swap with me to work in the integrated discharge team. I also had to cover her role in the early supported discharge team. So basically working as a senior therapist, occupational therapist across two teams. Normally that will be maybe altogether there'll be about 4 or 5 people, occupational therapists in those teams. So at some points it was just me having to cover that kind of workload. Of course, not doing all of that work, but kind of representing that. So I've had to do a few more virtual consultations. There's, patients and carers who do not want face-to-face visits, and but I'm still able to carry out face-to-face visits. Certainly, I've noticed that there's more patients who are discharged to care homes and who then needed support and assessments and rehabilitation to support them to actually return back to their own home. So that's quite, a significant work and pressure on the services for occupational therapy. I've also had to have a shave, so get ready for this. Yeah, so sexy beast on the left became I don't know, somebody's looking for work experience. So I don't know which one you trust more in terms of providing your care rehabilitation. Rachel, are you taking a photo? No, okay, right. And then an exciting thing, which I can look back and say it's exciting. At the time, it was quite an interesting, difficult thing. But working with the University of East Anglia, we offered placements, really. So UEA developed this recipe project, and it was an innovative student placement where they had 2 students to 1 educator and having more peer assisted learning. So normally we would maybe have 3 or 4 students at one time in occupational therapy across the organisation. We accepted 20. We were possibly going to offer 22, but we couldn't find a placement for 2 students, so we went down to 20. So this was quite a challenge in COVID in terms of trying to offer something quality placements. Students also had risk assessments that we had to manage as well, that some were limited in terms of the face-to-face contacts they could have, as well as trying to manage our services and deliver them. So what we had were two master's level pre-registration students, first years and second years. The first year students placements were deferred because it would have coincided very early on. I think it was about March, April time, so very early on in terms of lockdowns and the pandemic response. And they were supported by a second year MSc student who kind of provided a bit of mentorship as well. So peer assisted learning. What we did actually find is that they kind of supported each other, they mentored each other. It's like with anything, when we all have different backgrounds and different experiences, and we have different strengths. So actually being able to bring those elements to support each other was really great, and also being able to have them kind of work on things together, and they can go to each other for that support, and how do you do this and how do that. Some of the second years had more experience of using the electronic record system, so it was nice to have that kind of support, and for me as an educator to really be inspired by them and how they coped with that, and actually feeling that it is manageable in a difficult time to have two students. So actually I've agreed to take two students again together in May, June time as well. So for me, it's kind of being placed in that position of having to take two students just made me realize, yeah, this works really, really well. And I would encourage a lot more people to think about it. So if anybody's got any questions about that, feel free to contact me. Yeah, I mean, it was difficult at times, because I think some days I had 6 students to kind of supervise, but hey. And then something is probably worth directing people to is the Royal College of Occupational Therapists does have some free access resources as well on their website. So things on COVID-19, some general information, particularly directed to occupational therapists as well. But there's links to health and wellbeing advice, and advice that the public and any professional can access around post-viral fatigue and conserving energy, and some of the advice that's there. So that's kind of my little presentation, but I'd rather have a chat.
We've got lots of questions coming up, so
dear.
Great, you can hear us. So as a fellow OT, apologies for this difficult question, but just wondered how you describe the role of OT to patients, and has this changed with each redeployment?
I think I kind of explain it as I'm interested in things that you want to do and need to be able to do, and I use that explanation of things like maybe looking after yourself, looking after the home, looking after others, looking after your pets, going out and about, hobbies and interests, work, going to education and things like that. Whatever, what makes you is kind of what I can do. And I think through the kind of like when doing your initial assessments, then that is kind of explored. It kind of things are having a conversation as well, get to people. And I think I've got the luxury of some of my jobs, particularly from the stroke team and from the neurology team, is that I tend to be engaged and be involved for quite some period of time, so I can develop their understanding of my role over time and give that kind of explanation and take it a bit wider. Sometimes when people start opening up about certain things, you go, okay, yeah, let's talk about intimacy and sexuality. Oh, driving, yep, definitely talk about that. Oh, work, oh, okay, there's that. And there's, this is the hobby that you've really enjoyed that you never talked to me about, even though I asked you about hobbies at the beginning. Great, let's work on this. So I think that's why I like the job that I do, because I get to know people and build a relationship, and we problem solve and explore things together. I think in an integrated discharge team hub, it's like pushing paperwork and things like that, and it's very process driven, and that's probably why I was very unhappy and stressed and burnt out working in an integrated discharge team. So it was quite a relief to be leaving there, even though placed in a very stressful position of having 2 to 6 students working across 2 teams, having line management responsibilities for some staff across 2 teams, and dealing with a caseload that has not really been looked at for months on time. Yeah.
So that kind of brings us on to vocation, and I'm going to wrap up the 2 final questions. There's one just come in around recognition, so answer these succinctly, Ed. Vocation, is it vocational rehab? I think this is in reference to. So, you know, is this a real area of OT that we need to focus on, particularly post-pandemic?
Definitely is a thing that we have focused on and wanted to focus on in the past. Our history has been, you know, about vocational rehab, you know, following the First World War. Yes, there are special interest groups. Contact me if you want to find out more. Contact me if you want an ergonomic checklist, and I can kind of help you explore what you might want to think about in terms of understanding the work role.
Wow.
Oh, and what was it, cognition as well?
So yes, so do you have any advice or resources for other HPs to kind of comment on cognition? It's something a lot more to come with, like with OTs. So when you haven't got an OT in the team, and it's a really, because OTs are mental and physical health trained. So so any tips, any signposts?
Tips are always a huge topic. I think our focus on 3 questions is: what's your concentration like? What's your memory like? What you like making decisions? Because we can do standardized tests and find problems, but people get on with their lives. Or actually, when they try and get on with lives, that's when they're finding the problems. With memory, sleep is important. So lots of rest, because that helps to consolidate your memories. And stress is important as well. So don't think about just cognition by itself. Also look about mood. So as we're anxious and stressed, that reduces our ability to problem solve and concentrate, and doesn't consolidate our memory. So it's all complex. That might be another podcast, something, Rachel.
Well, thank you so much, Ed.
Absolute
You've been
pleasure.
amazing. Ed is Ed's more than happy to take questions on Twitter as well. Just reach out to him. He's amazing. Thank you so much.
Take care, everyone. Stay safe. Bye.
Now, moving swiftly on to Naaman, who is in his car, and he's going to explain why and what he's going to talk to us about. Now, do I need to share the screen on your behalf? Or are you going to try and do that?
I can do it. So you can hear me okay?
You are perfect, as always.
He says, and okay, give me 2 secs.
So this is a really important talk, because I think a lot of people just think you do one thing. So in your profession, and it's so diverse, it's unbelievable. So it's a great opportunity to learn a little bit more, and of course ask questions.
Sorry, Rachel, do you mind sharing my presentation for me?
I will really try. This is what broke YouTube last time, but we will. Let me just, do you want to start by just saying a little bit about what you're going to talk to us about? Can you see that okay?
Of course. I can, thank you. Hi everyone, my name's Naaman. I'm a therapeutic radiographer by background, but I'm also an advanced practitioner, so a band 7 level, just started at Imperial College in London. So started originally on the treatment floor, and then I've moved into sort of a specialization, if you want, as a rotation, and then now it's kind of my advanced practice even, is review. So side effects management, so psychosocial and physical side effects. So on the next slide, I'll just show you about, just very quickly, common misconception about radiography as a career. There are 2 different types of radiographers. One's a diagnostic, so our lovely colleagues who work in X-ray, CT, MRI, etc. So they'll use ionizing radiation to diagnose disease. So before patients come to us, cancer treatment, they'll have to be diagnosed with some form of tumor or even a benign condition that we sometimes treat. So I'm on the other side, so I use ionizing radiation to treat disease. So we see a wide variety of patients, depending on your geography. Each department will have specific sites that they focus on. So you've got all the main ones, lung, breast, prostate, colorectal, and some of the bigger centers might do some more advanced techniques if they have sort of more funding for more specialized equipment. So like stereotactic radiosurgery, so using, well, a very long appointment, but to treat a brain tumor. I should have said, sorry, Rachel, I forgot to mention why I'm in my car. Just started a new job in London, so I'm moving from Somerset to London. And yeah, so we're just in the services, just going back to get the last few things, and sold my flat finally, so dropping keys off. So yeah, that's why I'm in a car. Sorry. So on the next slide, just going into, sorry, Rachel. Going into radiotherapy, into more, so I'm not going to go too much in depth with it, but we use a linear accelerator. So if you imagine, if you've ever broken an arm or a finger or a leg, you've had an X-ray, for example, you would times that energy by almost 1,000, and then we can use that energy to treat cancer with it. So bottom left just shows the breakdown of a linear accelerator. They cost about £2 million each, so it's quite exciting when you do start working to be able to use this sort of machinery. We always work in pairs. So it's not a live source of radiation. So if you've ever watched like the TV show Chernobyl, it's nothing like that. It's just we build up the radiation by using electricity, and then it's accelerated. So thinking about physics over a waveguide, and then we'll bend it into the right shape. So if you imagine a tumor is not going to be the same everywhere. So all around in the body, it's not going to be a perfect circle, for example. So we can conform it, if you see with the jaws, they're called multi-leaf collimators, to basically anything you want to do. I know in training, they've been able to change it into like a smiley face just to show us the beam on a bed, so what can be done. And we work to millimeter accuracy. So on the bottom right, as you can see, that isn't a real life patient photo. Obviously, this is what we use for our pediatric patients, just to showcase what happens. You might be able to see Spider-Man holding a head and neck mask. So that's for our patients who have some form of head and neck cancer. So let's say an oropharyngeal cancer, say in the tongue, they'll need to be clipped into the bed. So Barbie, as you can see in her lovely long, that's probably Rapunzel with long blonde hair, but she's clipped in with a mask. And you would be on the bed for about 10 minutes or so. The treatment itself takes about 2 minutes, but setting you up is what takes the time. So the reason we clip patients in with head and neck cancer, as you can imagine with the anatomy, the millimeter accuracy we want, any small movement, that mask will clip them in. You can breathe. The pediatrics, you might be able to see on the bottom right, a couple of them have their mouths sort of cut out on the mask. But yeah, just to be able to, it's more for comfort, I would say. You can breathe through it. It's supposed to be tight, as I said, just to stop any of that movement. So going on to the next slide, please, Rachel. Obviously, this is what it looks like. It's a lot prettier than that one with the Barbie doll. So on the right, you can see on the top is where the wave guide would be, and then it would project down onto the screen. So this insert, radiotherapy for the past 100 years hasn't really changed much apart from getting more accurate. So back in the 1960s and 70s, so a long, long time ago, for a breast treatment, you may have had a hemibody. So maybe from the waist up, maybe even covering some half of your face. So we did see lots of bad side effects. Whereas now, to treat a breast, for example, it would be just the whole breast. And again, to millimeter accuracy. So the reason I'm going through with this is actually the techniques itself, they have just been advancing. And actually with COVID, all that's changed in this room would be how we approach the patient. So we may have had maybe 3 people in, so 2 radiographers, we always work in pairs. So a senior radiographer, so either a band 6 or a band 7, and then a band 5, so a junior radiographer. And then we may have had a student, or sometimes if it's really necessary, a family member. But you can imagine some of our patients, they do need a bit of extra support. But with COVID, it's only been 2 radiographers in, and all of our patients have had to wear masks. There was a time where head and neck cancer patients, sorry, Rachel, we just go to the next slide. There's a, so this is actually me in a head and neck mask. So I had one made just for some training videos that we did. So this is what a patient would look like. And there was a time with COVID when all of the rules and infection control factors were changing on a daily basis, that we would have to sellotape a patient's sort of mask on top of this mask, because you can imagine that's already claustrophobic enough, but to have a surgical mask on to try and protect us, that was one of the changes. So the techniques itself, all exactly the same. If anything, they're still advancing more, and I think there were a few clinical trials where instead of giving breast radiotherapy over 15 appointments, we cut them down to 5 appointments. So it's something that's been coming along for quite a while, but COVID has actually sped it up. The whole aim of it is that it's the same benefit for giving 5 appointments of radiotherapy treatment as opposed to 15. So the same clinical outcome, a lot less side effects, but ultimately for a COVID perspective, it keeps patients in the hospital for a lot less time, which is really one of the biggest changes. And it's started to look into different sites. So colorectal patients as well, they've been coming in for 5 fractions, and for other centres, they've been able to look at sort of prostate treatments as well, so about 5 appointments rather than 20. So if you think for one cancer patient who already is immunocompromised, from a COVID perspective, it was really good for us to be able to almost, push the research through so quickly that within a matter of days, we were able to have a patient who'd be coming for 3 weeks in a row only in for a week. So that actually meant that we got through the backlog of patients that had been delayed quite quickly and caught up. But yeah, so looking at this patient specifically, so part of my job when I was working just on the treatment floor, the treatment floor would be, I'd be operating this machine, setting the patient up, so in this case myself, setting myself up in for the treatment, comforting the patient if they can't tolerate the mask, trying to put some music on. So all of these interpersonal skills, which in my opinion, I think without a mask was a lot easier. With a mask, you're having to shout. It's quite difficult to calm somebody down when you're having to shout through an FFP3 mask from experience, but that's kind of what's changed for us. So just focusing on the head and neck cancer perspective for this patient, from a COVID perspective, they would usually, before COVID, we would have seen them on a weekly basis. So like what would be called a head and neck clinic. So they would be seen by the consultant, by a clinical nurse specialist, and then going into more the AHP side, so a dietitian, a speech and language therapist, sometimes an occupational therapist. All of this was as people were more, either volunteering to work elsewhere or were shielding or redeployed. Some of this actually fell onto our lap, and this is where my role as a treatment review radiographer, so managing the physical side effects, the psychosocial side effects, trying to get prescriptions, all of that fell into our lap. I'm not going to say it was easy because there's a lot trying to learn about different diets, different religion sort of diets as well, how to help head and neck cancer patients who aren't able to get support through local GPs. Some of you may know this already, but Macmillan Cancer Support, about I think 40 years ago, they lobbied with the government to ensure that cancer patients never have to pay for their prescriptions anymore. So for a head and neck cancer patient, it'd be about £1,000 worth of pain relief, laxatives, orals, kind of biostimulant salivas, etc., Difflam mouthwashes. You can think of the big bill, but trying to get patients during COVID to go and collect these was even more risky because most of these patients would have had chemotherapy at the same time. So that was another pathway we've had to develop in our own way, that with our local pharmacy, to get all of these drugs for these patients on a weekly basis when there isn't anybody else around. And obviously our teams are all stretched as well, but I think all patients want to help themselves, but I think as we all know, we want to push them to remember that there is COVID and they need to shield, not be going out, etc. So that's one of the most complex patient sites. Other sites were a lot easier. I think we started to prescribe or give out E45 creams for patients having sort of skin reactions. But ultimately what I'm trying to get across is the radiotherapy techniques have all remained exactly the same. If not, they're now getting even better, that we can have patients in for a shorter amount of time with less side effects, which is obviously fantastic for us in the long run. But yeah, all that really happened was less people in the room wearing horrible PPE, which I'll come on to in a minute. So next slide, please, Rachel. So although I'm a therapeutic radiographer, and I will bang on about how much we're far better than our diagnostic colleagues any moment I can, this is something that started from, which I'm sure you know from any presentation, from a patient going into A&E, COVID-like symptoms on the right-hand side. It isn't quite a chest X-ray, but this is a CT scan. It's just showing the crystal-like structures that come up in the lungs. That is very, it just shows COVID very quickly. So when we have been scanning, so we have a portable CT scanner on our radiotherapy machine, so the linear accelerator that we use on a daily basis for most patients. So for example, for a thorax patient, so if we're treating this patient's left lung, we noticed from evidence that came out of China originally from their radiotherapy teams, how crystal-like structures were seen on even a cone beam CT. So a normal CT scanner is very, very advanced, lots of different slices. You can see very, very good anatomy. A cone beam CT, which is what we use for our treatment, they aren't as sort of detailed, but we use them more for positional. So making sure their spinal cord is out of the way, making sure their tumor is within the right margins that we want to treat. So we noticed that when patients are coming in for their initial planning scans, for some patients, we saw some of these crystal-like structures, as you can see more closer to on the bottom left towards the spinal cord. So this is something that developed a little bit through radiotherapy, but working very closely with our diagnostic colleagues, that actually we were able to tackle cancer patients who have actually been shielding, or maybe have been just popping to the shops to get food, etc., they have been maybe asymptomatic, and we have picked up just from a CT scan where they're having their treatment that yes, they've got COVID. I'm sure you're probably wondering, did we treat patients with COVID positive? Originally, we weren't sure how to go about this because, as you know, infection control, if you worked in healthcare over the past year, every single day the guidance changed because it was just unprecedented. We didn't know what to expect. So what we moved to, following evidence from Italy and China, was having what we call a hot machine. So you may treat back-to-back COVID patients and have little cleans in between. And then at the end of the day, have a deep clean of all of the surrounding areas as well. When we noticed this at a pre-treatment scan, so even before they've started their treatment, we could either, with help with a consultant, make sure that they're treated safely, or if they're delayed safely. And we could notice that some of these crystal structures would start to almost evaporate. That's the best word I can use during their treatments when we're seeing them every single day. So I think for the future, it has really helped us from an imaging perspective when, as a therapeutic radiographer, your anatomy, I'm going to be honest, is not the best. A diagnostic radiographer could tell you everything because they do, they look at this every day. For us, in a review perspective, for my role, I know a bit about anatomy, obviously I don't need to, but looking at this imaging structure, I could see actually, are there more crystal-like structures near the tumor itself? Is the tumor reducing? Are they suffering from more fluid in the lungs because of COVID? Is there something else we can do to help them? So using the whole pathway, so imaging into reviewing patients, into helping with their side effects, and from a COVID long-term sort of rehab perspective, it has really helped us advance our practice. Next slide, please, Rachel. So talk about PPE. We love PPE now. I don't think I've ever used so much ever in my entire life. The bottom left is working in the review team, as you can imagine, and I think as Edmund mentioned before, nobody wants to come in. They want to come for their treatments because they're shielding. And if you can even imagine, some patients who were starting radiotherapy at the end of March or April last year, if they've had chemotherapy for 6 months prior, they've actually been shielding since 2019. So avoiding, I don't know, their nephews, their nieces, their grandchildren, other people. So actually we had patients coming in for treatment in March, April who hadn't seen anybody apart from someone on their doorstep dropping food off a family member or hugged anyone since maybe 2019 November. So this was the face they'd be greeted to on the right or on the left. So someone with a mask, and it was very difficult to even try and show some empathy or compassion to try and get them to understand, you need a treatment and I'm sorry, we haven't got time to talk. We're actually trying to not get you out the door, but we want to reduce the amount of time you're in the hospital and get you home back to where it's safe when we didn't know what was going on. So moving from face-to-face consultations virtually overnight to telephone clinics was a shock. I know lots of my colleagues don't actually like speaking on the phone. I don't mind it. I think it's quite nice. And I think we found from, over the past 6 months, more patients were happy to talk to you for longer over the phone about intimate topics such as, oh, I haven't been to the toilet to empty my bowels for the past 5 days. That sort of conversation over the phone seems a lot easier than face-to-face, which I'm not sure that is where your interpersonal skills are making eye contact. It can be a bit awkward if patients are telling you that to your face. So we couldn't sit next to each other. You'd be often sitting in an office having a long day reviewing patients over the phone, which I'm sure if you've been shielding or doing meetings from home on Zoom, it's really tiring. Talking to patients, you don't see them. I know now lots of our physio colleagues are using the NHS Anytime Anywhere, so that's probably the future for video consultations, which will be good. But yeah, I think from an interpersonal skills perspective, trying to empathize or be compassionate through the phone has been a huge challenge. So where you could use body language in a person, if they're twitching, not making eye contact, now it's just the tone of the voice. And that's something originally we really struggled with, but now I think we've probably become experts with. And I'm sure as anybody who's listening, if you're still working now within the pandemic, we jump when the patient says, oh, I'd really like to show you something. And you say, yep, come in. I will get a clinic room and I will see you because I haven't seen a patient properly in a while. So that is really nice. It's been a huge change, but I don't know. I think it's been quite nice. There's a lot that's come from it technology based. And I think from a side effect review perspective, when it's been virtual, we've also moved to having a secure email where patients can send their photos of, for example, a skin reaction from radiotherapy. And we've been able to send them a tool that we've used to grade it almost themselves. So I know we talk about empowering our patients a lot, but I think we have really been pushing for that, almost, not so out of choice, but it has helped patients manage themselves a bit better. And I think for the future, that would be really nice. Just when we can get patients in more and more and not have to wear PPE all the time, it would be very nice. Actually seeing people's faces. Sorry, and if you go to the next slide for me. I didn't want to bore you too much with all about radiotherapy. It's been a tough year with COVID. So I know Rachel is looking at the chat, and I'm hoping she'll unmute and do this with me. This is something I've used in quite a few talks over the past couple of years. So STEM talks in schools or for undergraduate, everyone. It's just a bit of fun. I don't want to make it all doom and gloom with COVID related. So these are all, this is an X-ray we use from our diagnostic colleagues, and on the right, 3 chocolates that I CT scanned in our scanner. If you're happy to just work with me, Rachel, if you go with me from 1 to 13, you tell me what you think they are, and anyone who's online, if you want to send in your questions or
Krishna, I don't know
what
if
chocolate you think it is.
Still here. Okay, number 1's got to be Toblerone.
Yes, that is a Toblerone. That's an easy one.
2 could be anything. 2 could be like right, I'm coming back to 2. 3 is Revels.
3 is not Revels. You're wrong.
Is it Maltesers?
No, it's something I don't think they make anymore, so it's a bit unfair. They're Mars Planet.
Oh, Mars Planets, okay. 4 is a cream egg.
Kinder Egg, yeah. So you
Kinder
can see
Egg.
this weird toy thing inside.
I don't have kids, so I get half a pint. 5, is that a crunchy?
It is a crunchy, yeah.
6, Mars bar.
Nope.
Snickers.
Snickers, yeah. You can see the peanut.
Peanuts. 7, is that dairy milk bar or something? Caramel.
No, it's a dairy milk. You're right.
8, no idea.
Fries, Turkish delight.
Turkish delight. There's it.
Yeah, it is a Turkish delight. Well done.
Yummy.
10 flake.
10 flake, yeah.
9
Number
cream
9.
egg. Oh, we've got lots. 9
Yeah.
cream egg.
Cream egg.
Oh,
You can
it's
see
2
the
a
lovely
Twix.
juicy creaminess in it.
It's 2 a Kit
which one's
Kat or
that,
a
sorry?
Twix.
No, it's a twirl.
Twirl. Laura said a twirl.
Nice, well done.
Well done.
Number 11. Number 11's pretty easy. It's one of the best out there.
Oh, curly whirly.
Curly whirly, yeah. Number
12.
12. Don't say anything rude, Rachel. You're live.
What's 12 people in the chat? What is it? It does look very phallic.
It does look very phallic.
What is it?
It's a chocolate, I promise.
What is it?
It's a Lindor bunny, as Easter's coming up.
Oh, bloody hell. Must be side profile. 13, anyone? Mini eggs.
Mini eggs, yeah. Well done.
Well done, Emily. Right. Well, that's been an interesting Q&A. So you're going to have to bash through these questions so we can move on to podiatry.
Sure.
I can ask a couple of these in the chat. Why do diagnostic radiographers go around in 2s? I think that's a great question because they do.
Go around in 2s. Diagnostic radiographers.
Yeah.
I don't know.
Like, when you do ward x-rays. I think it's because one of them does the machine and the other one puts the plate in, looks at the image and.
Exactly. I would also say, as a joke, one of them is probably making sure all the doctors and nurses are hiding behind the cupboards as the x-ray is going off.
That's responsible radiotherapy though, isn't it? Because you're protecting staff and other patients.
Yeah, that's diagnostic side though. But yeah.
Yeah. Okay. Just loads of comments about that. Was amazing. I've answered a couple of questions about the mask, but what is it made of?
So it's thermoplastic. So it comes with like a long sheet. You put it in a hot water bath and then you rest it over the patient, basically mold it. So it molds around and then it clips into our bed. So every linear accelerator machine, they have their own kind of headboards that they clip into. You can have head only ones as well if we're doing brain treatments or prophylactic cranial radiation. Those head and neck ones is to make sure the shoulders stay in the right place and to stop any shoulder rotation, because that can affect sort of the area that we want to treat.
I just want to sneak in there. Occupational therapists use a foam plastics as well, so you might want to have a visit to your trauma and orthopedic and therapy, occupational therapy colleagues to have a play.
And
Or your neuro OTs.
That was a great thing in the chat was about that, and how you lovely, very nicely touched on how your work can impact on other therapies and the need follow-up. So great how it's all interlinked. Thank you so much, Ed. Thank you so much, Naaman. Now you can reach out. You can reach out on Twitter if you've got any more questions. Please do. You really don't mind, don't you? Not. Okay.
Not at all. Go for it.
Fab. Krishna, next over to you. Then we've got a break. So we're going to talk all things podiatry. I'm so tough now. Do you have a presentation you would like to share?
Do this properly, because the last time I did it I messed it up. So.
Oh, that looks amazing.
So how's that? Can everyone see that?
Yeah, it looks great. It looks lovely. Thank you. I
thought I would continue the rainbow theme as you've got. I've even got a rainbow t-shirt on as well to keep it going.
Yay.
So yes, hi, thank you for giving me this opportunity to talk about my profession, which I'm very, very passionate about. I'm an advanced podiatrist working in the NHS. My specialist area is diabetes and high risk foot, so I deal a lot with wounds. But as we go along, I'm hoping I can give you a little bit more insight about podiatry and what we actually do as a profession and how we've adapted to COVID. So what are podiatrists? What do we do? So podiatrists are, if you look anywhere for any, what's the word? What we do, this is what we do, sorry. We're highly skilled professionals who treat, diagnose and rehabilitate any lower limb problems. And our aim is really to keep people mobile and active. And we are, if you want to get into podiatry, if anyone does want to get into podiatry, you can go straight from going, the routes into podiatry is that you can go via A-level straight to university. There are also apprenticeship routes available now, which are really useful for anyone who wants to, who can work. So you can work and go via an apprenticeship routes as well. And what's fantastic, I think, is seeing over the last few years how apprenticeships over all the AHPs have developed to allow all individuals to follow a career path. If you wanted to do podiatry, a typical course would be over 3 years in the UK. It is 4 years in Scotland and Ireland, but this is what year 1, year 2 and year 3 would actually look like if you were wanting to go study podiatry. And these are the sorts of subjects and areas that you would cover. If you wanted to study, there are lots of places you can go study podiatry throughout the UK, and I've just put up a little map of the UK there of all the different universities if you are interested to be able to get a little bit more information for. But podiatry is basically all over the UK, so you can go wherever you are in the UK to go study it. So on graduation, what can you expect? So you will get your degree, and as most of the AHP professions, it's a vocational degree. You are ready to work. The degree allows you to have you need to have 1,000 hours of clinical practice. So you have a lot of clinical practice before you finish undergraduation, leading to graduation. But on graduation, you also have your separate qualification of POMs, prescription only medicines, to supply and administer, so you are able to access your anesthetics, antibiotics, painkillers and antifungals as well. So you're already with that medicines, already with that experience as you're graduating through, and able to put that into practice. So when people think podiatry, think, well, actually, what do we do? There are lots of things that you can go into. So one of the main things, I've tried to categorize it really, because it's such a vast subject when I start talking about it. So if you look at biomechanics, we are specialised within the lower limb. We look at all the anatomy of the foot and the leg, and we do a lot of biomechanics, and we look at sports injuries as well. We've got podiatrists working for football clubs to help improve athletic clubs as well, so helping athletes to perform better by looking at the way their biomechanics are working and prescribing insoles. There's lots of amazing equipment out there to look at the different pressures, the way people are walking, to try and adjust and address any biomechanical functional deformities that may be, because actually if your feet are out, you can actually, your knees can be painful, your lower back can be painful, it can affect the whole body. So actually the biomechanics is actually quite a big area. And if you're working within the area of biomechanics, it covers not just adults, it covers children as well. And like I've talked about already, sports, athletics. So biomechanics is quite a vast subject. And what's nice is that there is a good crossover between physiotherapy and podiatry when it comes to the MSK side of things. So it allows us to have that cross working together as AHPs. You can go on to do podiatric surgery, so you can go on to do foot surgery. You can go on to study further to do foot surgery, so look at neuromas, bunions, arthrodesis. You can we work quite closely with our podiatric surgery colleagues in Northampton to manage our diabetic foot and high risk patients, and they do that, you know, our distal amputations and everything. So you can go on and develop your career into podiatric surgery. And wound care, which is my area of passion because I'm a diabetes specialist. I deal with a lot of lower limb wounds and diabetic foot ulceration. It's not everyone's bag, but it's something that I really, really do enjoy doing, and the impact that can have when you're getting something healed is phenomenal. With podiatry, you have the option to then go on and be a prescriber, which you can do in some other AHP professions as well. We do nail surgery as well, so if you've got an ingrown toenail, you can come to a podiatrist, and we can do that under a local anaesthetic. So in terms of the skills that we actually come out with and what we actually do for the population, it is quite vast. So in preparing for this particular presentation, I put a quick email out onto Twitter, and I said to my podiatry colleagues out there, can anyone send me any photographs of how they've adapted, because I can talk about how we've adapted, but I wanted to give you a big picture of what podiatry as a profession has done to adapt to our current COVID situation. I was inundated with photographs, so I had to pick and choose, but I'm hoping that I'm going to be able to give you a good overview of actually what we've been able to do. So again, I know everyone else has talked about it, PPE, where masks weren't really the norm, they've become the norm, and we've started you know, wearing them for all our treatments. And again, with podiatry, you can work in the NHS, you can work, you know, privately, you can work. I'm a lecturer as well at the University of Northampton, so you can, you know, education side of things have changed as well. So there's a whole lot of progress and things that you can actually do. So looking at these photographs at the bottom, you can see we actually introduced one of the changes and adaptations that we did was the introduction of screens in front to try and protect each other. At the top, you've got our lovely Martin Fox. He's one of our vascular podiatrists. We call him the evangelist of vascular podiatry, because you'll be quite amazed by what you can actually diagnose from listening to a pulse in the actual foot. And actually it's all about prevention, and so a lot of cardiovascular issues can be picked up, like atrial fibrillation, from listening to the actual pulses in the foot and getting those patients referred over to their GPs as soon as possible to get their cardiovascular medications sorted. But also it helps with our diagnosis with peripheral vascular disease and peripheral arterial disease. And we work really quite closely. If you look on the right hand side, this lovely picture with our vascular surgeons up in Manchester. One of the things I'm sure everyone has done over this period is actually embrace technology, where virtual telephones and virtual conversations were something of of the future. It's all being incorporated into daily normal life. So the picture on the right hand side in the corner is a picture of the the consultant podiatrist, the nurses and the vascular surgeon up in Manchester, and they did a virtual consultations with the patient being at home, and adapted and sorted out what needed to be done with this patient, and their clinical management plan was put in by embracing the way technology has actually been used. So I think one of the main things that's happened is that one of the things that felt quite futuristic, because when I was thinking about it for this presentation, I was thinking 2021. I mean, I remember the year 2000, and thinking 2020s was, something that's going to be really in the future and really quite scientific. And actually, when I think about it, I think, well, 2020, 21, and as time goes on, we've embraced so much technology and innovation. So I think one of the things is showing how, our virtual consultations have been so important for all our patients. We've been able to see patients who have been at home and actually advise them. I've got a picture in the next slide about a scenario where we've used virtual consultations successfully. There's been changes to the way people have been able to refer and access services. Our podiatry service, for sure, we've got now an email address, and patients who can email in their pictures of their feet. I've been telling people, get a selfie stick, get that phone at the bottom of that selfie stick, because as you get older, people always tell me that your feet get further away. Putting that phone on the end of that selfie stick and taking that picture of what's going on underneath, and then having a look, and then emailing those photos in for us to appropriately triage has been phenomenal. It saved us so much time. We've been able to clinically diagnose and triage more effectively and get those patients that need to come into clinic. So there's been a lot of PPE. We've kept our spirits up. So you can see the dab in the corner. There are a couple of my colleagues who've actually worked throughout this whole pandemic on the inpatient wards for treating any patients with COVID, but we've still got the diabetic foot ulceration and complications. And you may hear COVID toe being batted around, because that's a real thing where we've had, because of the little blood thrombi, they've blocked blood vessels, and we've ended up with patients who've ended up with gangrene on their feet and changes to their feet, colouring, circulation, and obviously we've had patients who've ended up with foot wounds, and we've played an integral part in being able to help manage these patients and help get them back up and rehabilitated. The picture there that we've got there of and that's just basically showing with the lower limb bandaging is the cross working that we've had. We've got, with wounds, we have transferable skills. So we've been working really quite closely with our district nurse colleagues and using our skills to help support their services. So in a lot of trusts, some of the podiatrists have been redeployed out to help district nurses with their care and take on the diabetic foot or high-risk feet that they've been redressing and going out. But again, people have just adapted in the way that they've been working. One of the biggest things podiatrists have been able to do is, because we have that injection skill at undergraduates, and we're using injection skills post-graduation and within our clinic, is taking an active part in the vaccination programme. And that's the three middle pictures around Scotland and down in Oxfordshire. It's just showing the input podiatrists have had in rolling out the vaccinations to the population. So on to the next slide. Again, there's lots of PPE. You can see that people have, really worked under quite extreme conditions, but it's been needed. And, podiatry in some parts of the country, podiatrists have been working in the morgue, moving dead bodies. We've been redeployed to help in all sorts of areas. One of the one with the 3 foot one, I didn't put too many gruesome feet pictures on, because I don't think gruesome feet people, it's everyone's bag. But at the bottom there, where you can see pre-COVID and 12 weeks in, and that was a patient who'd undergone surgery, and they looked after their redressings at home by themselves. We are empowering patients to take on that little bit more of their own care, and they redress their own foot, and it led within 12 weeks of having the operations to full healing. So a good part of all of this has been empowering our patients to take on a little bit more responsibility for the care of their feet. The picture, the 9 picture, is one of my colleagues up in Manchester. They've worked again with the practice nurses, the district nurses, they've worked with the vascular nurses, they've worked with inpatient staff as well, to provide any support and help, and actually use the knowledge and skills that we have as podiatrists with wounds and as prescribers as well, to keep patients out of hospital. So one of our main key points around here has been that, you know, when the pandemic first hit, was the use of hospital beds. So one of the main key priorities was to keep these patients out of hospital. So making sure that we're adequately offloading them, making sure that their vascular supply was assessed and getting them to vascular if needed, but making sure they had their medicines and actually had their prescription of antibiotics or IV antibiotics at home to keep them out of the hospital and safe in their own home, so that they could actually save those beds while COVID hit, and all the beds were being taken up by really quite poorly patients. And that's something we continue to strive for, is keep patients out of hospital, keep them treated within a safe environment, be it in a clinic or be it virtually within themselves at home, so that we can save those hospital beds for patients who really need them due to COVID. On the last bottom picture was a picture sent to me from one of my colleagues from the university, because as well as COVID being hitting and staff working extremely hard and adapting to what, you know, our environment, education has also been had to be adapted in the way we actually deliver it. So a lot of our lectures have been online, but you know, some of the places have got simulation feet which have been used to actually help can make sure that education has actually continued as well. So if anyone does want to have any further information on podiatry, what we do, I've literally give you a whistle top hurricane of what we actually do as a profession. There are some resources there which I'm sure Rachel will make available for everyone if anyone does want to go in and learn a little bit more about what we actually do. So I just want to say thank you for listening to me. I do talk really, really quickly, so I hope that you've been able to take on board. I'm really quite passionate as well about my profession, because I do really love my profession. I'm very fulfilled, and I've been able to progress and actually really make a difference, and that's one of the things that I really love. So I'm open for questions. I hope I've left some time for questions. So are there any questions that you want to ask me?
So thank you so much for that. That was amazing. Lots of lovely comments coming through. Just a personal one was, what do you love most about your job?
What do I love most about my job? So I love the fact that I do a variety of roles. So I like the fact that I can have that variety. I love that no day is the same. Every patient is different. To be able to problem solve and get them pain-free or healed and have that real true impact on that person's life, to be ulcer-free or pain-free, to be able to then continue with their life, that for me is a real a bonus for me. And I like problem solving, and I love working with people, but I also love the fact that I can work with lots of other professionals as well, so like vascular, orthopedics, the district nurses. I mean, if anything, I feel that this whole year has allowed us to create really positive connections with other AHPs and other professionals like the nurses and GPs. So I feel, you know, I love it all, if I can say.
Honestly, I wish you could see these comments. So they just said that was so inspiring. People didn't know a lot about, if anything, about your profession beforehand. It was fascinating. and people are calling you Krish Pod.
Yeah, KrishPod7 is my Twitter name. I'm happy to take any questions after this. But yeah, if we can inspire AHPs, we're a fantastic profession as a whole, umbrella term. There's lots of amazing professions under that term of AHPs. I just happen to be a podiatrist, and I'm very passionate about my profession.
I think that was the reference, just how you're so passionate and about being a podiatrist. Do you work day to day with dietitians, for example, when patients have diabetes?
We do. So part of our MDT, so multidisciplinary team at the hospital, we've got close connections, and luckily our dietitian's office is literally across the corridor from us. So we have a really close working with our dietitians, and we work together really quite closely. So yes, we do have dietitians on board, and referral process is really, really quite easy now, to be able to just refer our patients who feel that they want to have that little bit extra input. What I would advise, if anyone wanted to know a little bit more about podiatry, is find a podiatry clinic close by or a private podiatrist. We're quite a friendly bunch. We're more than happy for people to come in and see what we do, even other professionals to come in. We quite often have the district nurses, practice nurses, even GPs. We've had lots of people come into our clinics to see actually what we actually do as a profession.
Well, thank you so much. Thank you so much for being on time. That was absolutely fascinating and so colourful.
Yay!
So, mission accomplished. I want to thank all the speakers on this session today. Thank you so much. Please do have a short break, and we will be back here at 11:50. We do have a physiology, dietetic and paramedic session coming up, and then we will have one final session. So thank you so much, everyone. Just join on the same link on the YouTube live on AHP Leader YouTube channel, and these will be up to view forever.